Hi everyone, how was your quiz? Good? Good. We'll go over the results after, okay? So we'll talk about invasive cardiac monitoring. So what we're going to do today is first explain the blood flow through the heart. Again, we're going to go through that. We're going to define cardiac output. We're going to list the reasons for low cardiac output, and then we're going to look at the waveforms and pressures inside the heart to see what we're responsible for as the critical care nurse. So let's go through the blood flow one more time. So you're going to enter through your right atrium, through your tricuspid to the right ventricle, through to the pulmonary artery, out through the left pulmonary artery, get our blood oxygenated, then come back through the left pulmonary vein into the left atrium, down the mitral valve to the left ventricle, through the aortic valve, and out through the aorta. So that's how our blood flow is, remember, from our last lesson. So cardiac output equals heart rate times stroke volume. What does that mean? It's the actual amount of blood that's pumped into the aorta every minute. So this is actually about 5 liters per minute that's going through, and it's the blood that's circulating throughout our body. If we look to see what that really means is that all the blood flow that's coming in through the venous return should equal the cardiac output that's being pushed out. So, and then it's distributed to all the different parts of the body. So what goes in through our venous must come out so that it recirculates that oxygenated blood. Now, when we have low cardiac output, that isn't very efficient. So there are 2 reasons for that. Either we don't have a good pump or we don't have good return. So when we don't have a good pump, that means that there's some type of blood vessel blockage, like when we have an MI, like we have valvular disease, myocarditis, or tamponade. When we don't have good venous return, that means that our blood volume, like from shock or from loss of blood or hemorrhaging, a venous dilation, obstruction of the large veins, or the muscle mass is missing. So all these things cause decreased cardiac output. Now, when the physicians want to see what our cardiac output is like, because we have such critical illness, they usually ask for something. You guys know what that is? How do we monitor that? Now, there's non-invasive ways like the flow track, but there are also invasive ways that we can do that. So what are they going to ask for? They're going to ask you to bring out the swan. So this is what the box would look like here. They're going to ask you for the swan box. It's usually the only one that we have inside the hospital. So when you're going to be in charge of that, there's certain things that you as the nurse are in charge of. This part here you'll open, so that's still sterile. So then you'll be in charge of the cables here. So this is our thermistor here. The thermistor is connected so that you can get the core temperature, and you'll also be able to calculate the cardiac output. This is a SVO2 cable, a continuous SVO2 cable. So mind you, while you're doing this, the physician will be sterile. So when you actually give it to them, they are picking it up sterilely, okay? The first thing that you do when you open it is you need to test the balloon, because there's going to be a balloon there that you need to float through. So the syringe is already inside the box, and it only goes 1.5 cc's. So you can't push it any more than that, or else the balloon will pop. So what you do, this is the red port here, you connect it, and you blow up your balloon to make sure it's intact, okay? So push it through. It only goes 1.5 cc's, and you see your balloon's intact. When you're letting it deflate, let it deflate on its own. You don't want to make sure that it has any increased pressure. And make sure that every one of that 1.5 cc's, every single, there's no more air in between, okay? You're also going to look at your lumens. It's usually by color. Your yellow lumens, your PA catheter. Your blue one will sit in your CVP. So these 2 will be transducers that are actually, they'll be transduced so that you can collect the pressure. And we'll look at the waveforms and the pressure soon, okay? And this is your proximal infusion port. So this is where all your drips are going to go. If you look down the line, there's actually 2 thick lines. Each thick line is equal to 50 centimeters. Okay, 2 of these is actually 100. You'll go down, you'll see there's smaller thin lines. Those will be 10 centimeters each. So this is 90, 80, 70, and 60. And then there's one line here, so this is equal to 50. When the procedure is done, the catheter usually lies at the hub between 50 and 60. So your different lumens you'll see here, there's two that'll sit here. This is for your right atrium to collect your CVP pressure. So this here is your thermistor. So this is what's collecting your cardiac output and also your core temperature. And there's the end for the balloon. Okay, so this is your swan. Now you have to be careful while the swan's being placed because this is going through all the different valves of the heart. So the potential complications could be rupture. You could rupture one of the valves. If you rupture your pulmonary valve, you could bleed out and your patient could die. So you have to be careful of those things, okay? You could also perforate any of those walls. So this is very important to look to make sure when the balloon is inflated and deflated. All right, so the indications are shock, pulmonary edema, tamponade, pulmonary hypertension, all the same things that we looked at before, right? The same exact ones for low cardiac output. So as a nurse, you're going to be in charge of these things. While the physician is going through putting this catheter in, you're in charge of knowing where they are, determining the pressure, and the waveform here. So here, this is basically our CVP. So our CVP is between 5 and 10, low pressure, and a low waveform. So then you float through to the right ventricle. So this is the part when you really have to check for arrhythmias because nothing wants to be tickled. Your right ventricle doesn't want to be tickled at all, right? So you'll see these higher waveforms here. This is about 25 millimeters of mercury. And then you're going to go through to your pulmonary artery. Again, make sure you look for arrhythmias. But your pulmonary artery pressure is going to reflect basically like your right ventricle. So again, the 25 millimeters of mercury as your systolic pressure, your low diastolic about 8, and then your means about 10. And then they're going to go all the way up to wedge themselves into a arterial. So there, they'll wedge the pressure to try to measure the actual left atrial pressure. So you inflate the balloon so that it's getting all that pressure back, and it usually lies between 8 and 10. So you want to make sure that they don't inflate that balloon very long because you're blocking all of that blood flow. So here's your pressures again. 5 and 10, the right atrium, your left ventricle about 25, your pulmonary artery about 25, and your wedge about 8 to 10. So now you're going to do this on a real patient. Your physician is there and you see this waveform. Where do you think you are? It's low pressure. That's right, you're in your right atrium. Very good. Now when you compare it to the textbook, it looks pretty similar, right? Good. So then you're here. Your pressures are higher, but no notch. Where are you now? In the right ventricle. Compared to the textbook, pretty straight on. This physician's doing very well. Okay. Next, you move along. So where do you think you are now? Perfect. Your pulmonary artery. So compared to the book, perfect. Okay. So then you see that little change here? What has he done? He's inflated the balloon. So that's your wedge pressure. And he's not there very long, you can tell, right? He doesn't want to sit there for very long, but he's in the right place. And compared to the book, he's not right on point. Okay, so what do you do after that? You can't wedge forever. So you deflate the balloon, you'll pull back, and you'll sit right back in your pulmonary artery. Okay? And after all that's done, what do? You get a chest x-ray. So you're sitting right there, which is perfect placement. Okay? So you as a nurse have to know all of these steps because they're counting on you. So in conclusion, your cardiac output is the quantity of blood that circulates throughout your heart. And when a person has low cardiac output, you need to have invasive monitoring and need to help with that. So you need to be able to differentiate the waveforms and the pressures of the catheter. Okay, so let's go and do this in the skills lab. Any questions?